would love to introduce this session in a more poetic way. So when organs are failing and your hopes are wailing, standard therapy is working slowly where you are stuck up totally. શું લાગે છે ડોક્ટર પરી આગળ શું કરવું જોઈએ?
We can try circuits, filters or cartridge, borrow us extra time the way they bridge. So, to give us more knowledge about the extracorporeal therapies practice changing update, we would like to welcome Dr. Manoj Singh sir, and we request chairperson to introduce to sir. Thank you so much.
ISCCM body who had started 11 years before the first Gujarat Criticon in Ahmedabad, and that is sir, your whatever work has done till now, you are seeing that one. He is a consultant chest physician and critical care specialist of Zydus Hospital and Research Center, Ahmedabad. Sir, your stage is yours.
Thank you, Manoj bhai, thank you. So, and a topic પણ તમે મને આપ્યું છે એક્સ્ટ્રા કોર્પોરિયલ થેરપી. સો મનોજ સિંહ અહીંયા છે અને આ એક્સ્ટ્રા કોર્પોરિયલ ત્યાં છે, એટલે હું અહીંયા જોઈશ કેમ કે હું એક્મો પર જવાનું છું અત્યારે, બરાબર છે? સો લેટ્સ સ્ટાર્ટ ધ ટોક. So thank you Gujarat Criticon for giving me a very wonderful talk, because entire body needs support. You also need rest. I'm sure you have had a good sleep last night, good breakfast in the morning, and your body is about to fail. So I have help coming in by Dr. Raj Raval, because he's going to also speak on some subset of this. Then Milab tomorrow is going to speak on some subset of extracorporeal. So those two slides I have categorically missed. So let's start with the first slide. That's the red book which has been launched a few years back. Can I have my slide speak? I can see here. Can I have the slide? Yes, so the red book now, it's the first time in the world the multinational collaboration has come. All the bodies of the world have united for extracorporeal. And જેમ તમને ખબર છે તમારા hair dye, ચશ્મા, મસ્ત cold drinks, આ મારી જેકેટ બધા $100 થી અંદર મળે. આ $100 થી નીચ છે. Please purchase this red book, and it is a bible of extracorporeal therapies. બધા ECMO કરતા થઈ ગયા, પણ જ્યારે ફસાવો ત્યારે ફોન અ ફ્રેન્ડ કરો છો. I'm sure this is the best friend you should carry with you when you are doing ECMOs or any extracorporeal therapies in your intensive care unit. So let's start from the heart. આપણે બધા ઓર્ગનનું extracorporealમાં where we are, let's see. So the goal in extracorporeal for the heart is to improve, keep the patient alive, because heart ની વાત છે. Keep the alive, keep the organs working, because heart is taken away from the body with various mechanisms which we are going to see. To prevent multi-organ failure, to provide iatrogenic damages due to the existing vasopressors and the inotropes, and probably salvage the kidney, which is the next failing organ. So that's the goal of extracorporeal cardiac support. Now there is a new term from hemodynamics, as you see here, to hemometabolic salvage. We all know acidosis, we all know lactate, we all know the skin perfusion goes for a toss when there is a cardiogenic shock. So the goal here will be, as you see here, the hemometabolic salvage. So all of you will pledge today, any patient who is into cardiogenic shock, no matter what the cause is, even if cardiologist is very insisting on doing percutaneous coronary intervention, but your job starts from the first time the patient is with you. As you see, you have to avoid the tachycardia is happening, the drops not climbing up, the renal function, the subsequent liver dysfunction, and the coagulopathy not worsening. So that's your job, and I'm sure you do your job well. And if you see here, unless you bridge this hemodynamic support, the hemometabolic salvage is not going to happen. There is no point of putting 3 machines on a patient who came with a cardiogenic shock in current era of 2025. We all know the indications of ECMO, but remember, ECMO done for cardiac and lung has very, very refined role in salvage. It is not the cure. Please patient ને ના કહેતા આજે ECMO મૂકીએ છે સારું થઈ જશે, પૈસા થશે 8-10 લાખ રૂપિયા અને 4-5 દિવસમાં સારું થઈ જશે. There is no 4-5 days. Every hour counts if the patient is actually salvaged with a machine which is outside the body, and probably you are not well versed in it. So my 1 decade of ECMO, we started from Leicester. I still do not know even 50% of the ECMO machine, because I am not a perfusionist, I am not a cardiac surgeon, and I am not a nephrologist. So if I don't know, I feel you also don't know, because we are not going into the depth of intensive care as far as extracorporeal machines are concerned. So build a team, know the indications, always do ECMOs for patients who do not have underlying chronic disease. Please ILDs, please CLDs, CKDs, માં ECMO કરો તો you have to have a pinch of salt. Don't say that બધું સારું થઈ જશે. Don't give false claims. તમારા surgeon કરી શકે false claim because they are giving them confidence for the procedure, not for the outcome. Remember, there is a big difference between what you do, what you say, and what they do and what they say. In current era, there are a lot of hybrids. So, જે ECMO કરતું હોય, ECMO માં તમને ના આવડતું હોય તો you should not do ECMO. Don't call a friend middle of the night કે ECMO માં chattering થાય છે, clot થઈ રહ્યું છે, patient deteriorate થઈ રહ્યું છે, and મારે hybrid કરવી છે. Hybrid નું word એવું છે, actually ડર લાગે, because એક બાજુ સેન્ટ્રલ લાઇન હોય, એક બાજુ આર્ટરી લાઇન હોય, એક બાજુ પેલી બે કેન્યુલા હોય, જે મારા હાથ જો કેવા બંધાયેલા છે અત્યારે. So બધું બંધાયેલું હોય and you want to go for hybrid or you want to do the vent directly, it is difficult for an intensive care to justify the catastrophic consequences of ECMO, and when you want to actually do hybrid for whatever reasons you want to do hybrid. So whoever is doing ECMO, always have a plan B, plan C, plan D ready. Not more machines and more money or more blood, more FFP or more heparin will salvage the patient. Complications are many, but the last two things are very important for you. Always have a cardiothoracic member with you on board in any ECMO program. તમે VA કરો, VV કરો, તમને લાગે આ તો મારું જ કામ છે, હું સેન્ટ્રલ લાઇન નાખું છું ને ECMO નાખી દઉં છું. Don't do that because you might be in a SU. અત્યારે તો એવા મેડિકો લીગલ કેસીસ આવે છે અમારી પાસે that we really think what we are doing, what our colleagues are doing. For ECMO, please have a cardiothoracic member on team. A cardiologist always on team. Let him do the official echo before you put them on VV or VA ECMO. And cost, futility, રોજ ડિસ્કસ કરવાનું, રોજ. એવું નથી કે તમે એક દિવસ કહી દીધું, સાઇન લઈ લીધી, ઓડિયો વિઝ્યુઅલ કહી દીધું, then they are okay, but they are not okay because actually they have false hopes કે આ મશીન મૂકી છે, પેશન્ટ કોન્શિયસ છે, બધું સારું દેખાય છે. So with that, we move to the next heart support, that's the LVAD. And not going to LVAD detail because that's not our forte, but એવું નથી કે આપણી પાસે patient નથી. We have a lot of patients who need LVAD, but we are not actually explaining them. It can be the bridge to transplant, it can be the destination therapy, it can be bridge to decision or bridge to recovery. Bridge to recovery very rare છે, but that is what LVAD means to all of us. After the rematch trial, the LVAD invention or discovery was justified in the world, and people started making a lot of machines. This is actually the first generation LVAD. This is the second generation LVAD, which showed 48% mortality reduction with standard of care without ECMO. Now they are doing a trial with LVAD and ECMO in acute settings as well. And now this is the third generation ECMO, which is LVAD, which is available, and it uses the centrifugal low flow pumps, which we use it in our ECMO. So this is about LVAD. Then come lung support system. I'm skipping one heart support system. We are going to come back in kidney. So that's the echo and the ECMO. So when you put patients on ECMO, VV ECMO, there has to be a high risk of death despite optimal medical management. So you can't say कि oxygen ઓછું થાય છે તો હું ECMO પર લઉં છું. એવું નહીં બોલવાનું. You should say there is a high risk of death if I don't put patients on ECMO. And you will also be surprised to know that there is no trial in the world कि hypoxia થી કોઈ મરી ગયું. Because kidney વાળો શું કહે, dialysis કરું છું, kidney બરાબર છે. Blood વાળા શું કહે, blood આપી દે છે, platelet વધી જશે. But you can't say હું ECMO કરું છું, બધું ઠીક થઈ જશે. But you should say there is a high risk of death, diagnosis of a reversible cause I have done, and there are absence of contraindication to begin with when you start a patient on VV ECMO. Every ARDS is not viral fever. Every ARDS is not reversible. Remember, there are patients in even Gujarat who are coming with primary connective tissue disorder causing autoimmune lung hemorrhage. Primary ARDS are also coming for the first time in ICU, and they are potentially non-reversible. પછી 14 દિવસે સોરી અને સેકન્ડ ઓપિનિયન ના બધું નહીં કરવાનું. ફર્સ્ટ ડેજ, take your time, prone, reprone. We are doing now extended prone for 24 to 36 hours. ઉતાવળ ECMO પ્લીઝ કરતા નહીં મૂકવાની, because when you put it, you are fixed. લગન થઈ જાય તમારા. પછી સામેના consequences બહુ અઘરા હોય. અને આ really લગન થઈ જાય. When you do ECMO, I know we have done ECMOs for 45-50 days, and the patients, હું 2 દિવસ છૂટી લઉં તો પેશન્ટ ક્વેશ્ચન કરે હું 4 દિવસ ક્યાંક જાઉં તો ક્વેશ્ચન કરે બીકોઝ એ આપણા લગ્ન થઈ જાય ECMO કરીએ તો. સો રિમેમ્બર ધીસ, પિંચ વિથ અ પિંચ ઓફ સોલ્ટ when you start doing ECMO. And dictum આપણું છે કે no lung no problem, આપણે ECMO કરીએ છીએ, we are ECMO specialist, we are proud that we are also members. But remember, all the trials તમારે ડિફેન્ડ કરવું એ કોર્ટ ઓફ લોમાં. So if you have done an ECMO in a patient with contraindication, and I'm very surprised to see this slide, all the different trials done in the world have a really overlapping contraindication. એટલે બધા, everyone wants to play safe. So the next message for you is play safe when you do ECMO. Your patient should not have any of this contraindication when you are putting ECMO, because that is printed on the paper. તમારા વકીલ જ માંગશે કે સાહેબ બતાવો ને contraindication નતું. So if you are putting an ECMO in a patient, in a haste, in a obese patient, young patient, then you might be in a trouble if something goes wrong. Then comes next slide. Then comes ECMO, which is worth mentioning to intensivists because it is a new area and there are a lot of machines in the market now. Oxygen is in the hemoglobin in the blood, as you know, but most of the carbon dioxide is in your plasma. And normally when you are breathing, I am breathing a little faster because I am speaking in front of you. You are actually removing 200 to 250 mils per minute carbon dioxide. What happens in ARDS when, as Sumit said, you are going to go LPRV, lung protective respiratory ventilation, or you are a COPD guy, your production of carbon dioxide is 25% more, and that is into the plasma. And that causes detrimental effects on the right heart, and that is where your patient starts deteriorating in hemodynamics. તમને લાગે sepsisમાં જતું રહે, but that's not the case. If your carbon dioxide are mounting in an acute case above 60 also, your RV goes for a strain. In COPD above 70-80, he may go for a strain. So the concept of ECMO is remove this carbon dioxide which is in the plasma by various mechanisms. So I'm going to just highlight the various mechanisms. The physiological benefit are many. You can take the slides from me, from the organizers. This is what it is. There are various systems, even in VA ECMO, or when you put a AV system, the membrane is a part of the circuit. You can put one in the femoral jugular vein and the femoral artery. That is the AV ECMO. The rest are the VV ECMOs, which are more prevalent, more easy to do. And as you see, you can have a pump and a membrane in series, in tandem, or parallel, or emerge between each other. So that's how the ECMO works. The beauty of ECMO is this slide. You don't need high flows as ECMO. You can actually remove the carbon dioxide because it is 1,000 times more diffusible in blood than the oxygen. So તમે ખાલી sweep gas ની રમતમાં જ as low flow as your CVVHD 200 to 400 mils per minute માંથી તમે carbon dioxide કાઢી શકો છો. And you can actually use the same dialysis catheter which you use. Nowadays there is a new machine which can give you ECMO with CRRT. So તમે આ કરી શકો છો. The most studied indication for ECMO is actually COPD exacerbation. The ARDS, not a good candidate for ECMO, but has a little bit of gray areas for ECMO, but has permissive hypercapnia causing hemodynamic compromise. And third is an ILD patient waiting for a lung transplant. You can just do ECMO because he's used to hypoxia. So these are the accepted studied indication for ECMO. Then comes IABP. Current update for IABP is it is a good machine. It is available in all hospitals. All cardiac surgeons are very happy with it. We are not happy with it because our exam failing question હતું. IABP નો graph દેખાડતો તો કંઈ ના આવડે. So but at least indication in current era you should know. Consider IABP for refractory ischemia and mechanical complication in a patient with acute coronary syndrome or patient in the OT. But for routine IABP in cardiac shock is not recommended. That is the guideline. ISSM also says selective use in mixed shock or as a bridge to ECMO or LVAD. આપણી પાસે ટીમ આવી રહી છે. ECMO નાખતા નથી આવડતું. IVP નાખી શકે છે. So do it. Then comes the liver. So liver is a very, very heterogeneous organ, as you all know. The toughest organ after skin. તૂટી જાય તો બ્રેક રિવર્સ પણ થઈ જાય. પણ લોંગ તૂટે અથવા it has an acute potential for the patient to go into brain edema, acute kidney injury because of the hepatorenal syndrome, and patients can have acute or chronic. So the liver support system are different, as you see here. The scene in the target are different, and the synthetic change is because of the lot of protein-bound substances, albumin, bilirubin, and ammonia. So the liver support system can be used as a salvage, the bridge to recovery, or bridge to liver transplant. So whenever there is a patient with acute liver failure in front of you, always think about a liver support system. Unfortunately, in the current era, you don't have a paper which says कि salvage થઈ જાય. તમે ALF ના પેશન્ટમાં salvage કરવા માટે તમે any liver support therapy use કરો. Salvage થતું નથી, but Vishal is sitting here, my colleague. He does a lot of acute liver failure salvage. He avoids transplants in most of the patient. જેને સગાઈ હા પાડી દીધો કે ટ્રાન્સપ્લાન્ટમાં કરી દઈએ, પણ 5 દિવસમાં પેશન્ટને બહાર લઈ આવે છે because he is very fond of extracorporeal support. He's got a rich experience in extracorporeal support in liver because we are a liver transplant unit. But for the liver, there are 4 ways. The most accepted and the studied is albumin dialysis and the plasmapheresis. Plasmapheresis is not class 1 indication. We'll have a plasmapheresis slide. It's class 2 indication after standard of care. But class 1 indication is albumin dialysis, where your patient's albumin-borne toxin and ammonia is removed. So there are 3 systems. The most studied and the most actually positive response comes from Mars or Prometheus. The third emerging therapy is the SPAD. The only problem with single pass albumin dialysis is you have to waste the albumin. You have to just throw the albumin in the basket because that will be absorbed with the toxins which are there in the blood. Not going to detail of these things. I think previous speaker is said irrigation. મારા હાથમાં કંઈ નથી. મારી slide on. So plasmapheresis. Going to plasmapheresis now. So plasmapheresis નું જે actually role છે એ છે to remove the abnormal collection system in the blood. So plasmapheresis can remove your antibody in the GBM disease, myasthenia gravis, and the GBS, monoclonal proteins, circulating immune complexes, alloantibodies, and toxins. That is the goal of plasmapheresis. The other things which help in plasmapheresis is reconstitution of reticuloendothelial systems and removal of inflammatory mediators. That's the goal of plasmapheresis. Can I have my slides on plasmapheresis? There are 2 types of plasmapheresis. Mostly all of the intensive care units are very well versed with nephrologist-driven plasmapheresis. So that is called, thank you. That is called the membranous plasmapheresis. જે nephrologist કરે membranous plasmapheresis હોય and જે blood bank વાળા કરે centrifugals કરે. So the new thing is all of you should encourage your blood bank to do the centrifugal, that we have both facilities. We are going to come to that. Let me come back to the class 1 indications. So there is a guideline for plasmapheresis. Class 1 indication is you have to do it. We are now doing in all of the tropical diseases because that's class 1 indication. Anyone with any of these things, TTP is class 1 indication. We recently had 2 scruff typhus patients had confirmed TTP and we did plasmapheresis, patient got better. So you have to do this plasmapheresis in your intensive care unit, category 1. Category 2 cases are those where accepted care is ongoing and the patient is not responding, and the indications are listed all over here. Then these are the basic mechanisms which I told you. The membranous is the nephrologist domain. The centrifugal is with the blood bank. Centrifugal advantage is hemodynamic is safe. The biggest advantage of centrifugal is, as you see here, the blood flow needed is actually only 10 ml per minute. So patients on a hypotension hoy, so when you can use a centrifugal. And the next advantage, as you see on the next slide, is 80% of plasma is removed. It is very effective. It is more effective than your તમે 5 cycle જે કરો છો alternate day કરો છો એની કાંઈ જરૂર નથી. We use now more centrifugal than membranous because again cost તો સરખી જ પડે, બધામાં 5 FFP આપવું પડે કે 5 dialysis. So that is more patient friendly. આની અંદર heparinની પણ જરૂર નથી. You can use citrate. So that is a message for all of you. So that is what it is. Then comes heme adsorption, which I told you Dr. Raj is going to take on sepsis. And Milak is going to take on heme adsorption of poison, but the indications are very important. Why heme adsorption has come into play is because of the molecular weight, protein bonding, volume of distribution, water solubility, and the endogenous clearance. These are the 5 systems in the world studied, and આપણી પાસે બધું છે. ઇન્ડિયામાં every hospital will have this. ખાલી તમારે nephrologist દોસ્તી કરવી પડે. જે તમે હેરાન કરો છો, આવો જાઓ ડાયાલિસિસ કરવા, એને હેરાન ના કરો, એની સાથે રહો, અને એ તમને કરી આપશે. There are standalone filters, the HA280 and the HA30 is available in Gujarat, that are for the poisons, and you can do the PFAT, that is a plasma filtration and adsorption in parallel, or in tandem, that is a PFAT, HA with CRRT. All solvents are available in Gujarat for said indication. Then you can have the double plasma filtration. I will take 5 more minutes. 5, if you remember. And then comes the heme adsorption and the HDCRT. These are how the coupling happens with the sorbent filter. These are 5 accepted ways you can do heme adsorption. The indication, the toxins removed are methanol, ethylene glycol, lithium, salicylate, valproic acid, theophylline, carbamazepine, phenobarbital, phenytoin, paraquat. So we have a talk on paraquat tomorrow. Plasmapheresis, the toxins, immune complex, paraquat, which has limited role. CRRT, metformin, lithium, valproate, ECMO with filter can have beta blocker. So recently we had a patient with 30 tablets of metoprolol and 30 tablets of amlodipine. So it was a combined filter. We did ECMO and we avoided the filter because we did ECMO within an hour of arrival because patient had his cardiac arrest. With ECMO only the patient survived, but we had to put a CRRT. So we did ECMO and CRRT. We were just wanting this filters, but without filter only, patient bachegu. We did ECMO for 5 days. So 60 tablets of beta blocker and calcium channel blocker. So application of hemoperfusion of filter. So now there is a guideline for poisoning. Milab is going to take it tomorrow. I'm not going to go into detail. This. Then comes last but not this, our favorite, dialysis. So in dialysis, I have to take a word here. In patients with heart failure, જે તમે લેસિક્સ, ડુબીટામાઇન, ડાઇટોલ, ડુબીટામાઇન આપીને renal failure કરી દો છો, try this modality called SCUF, which is not a new modality, it's an old modality. So જે કાર્ડિયોલોજિસ્ટ છે ને પગ જોઈ, આપણે લંગ જોઈએ. કાર્ડિયોલોજિસ્ટ શું કરે, પગમાં સોજા નથી, ડાઇટોલ બંધ કરીને જતા રહે, પેશન્ટ બાઇક પર આવી જાય રાત્રે. So that is called, the new concept is called central hypervolemia. If the patient has orthopnea, he has white lungs, he has lung lines on the ultrasound. So that's called central hypervolemia. Central hypervolemia can be only removed by cardiac transplant, number one, bridge therapies, which we discussed, and SCUF. We do SCUF routinely. SCUF માં તમે per day 5 લિટર પાણી કાઢી શકો. ડાયટોર ઇન્ફ્યુઝન થી 1.5 લિટર કાઢી શકો. એનાથી વધારે કાઢો તો શું થાય, કિડની નારાજ થઈ જાય અને કિડનીના પેશન્ટો આમે હેરાન હોય અને હાર્ટ અને કિડનીના પેશન્ટ bill વધી જાય ડામા લઈને જતા રહે, you know, because we are not mature for cardiac transplant in our country. So try this SCUF, that is very important. અને તમારા નેફ્રોલિસ્ટ કરી શકશે, પ્રેમથી નેફ્રોલિસ્ટની દોસ્તી રાખવાની, ચા પીવડાવવાની. બરાબર, goals of dialysis is never improving kidney function, or if you know that, તમે એના કહેતા કિડની સારી થઈ છે, ડાયાલિસિસ ચાલુ કરીએ છીએ. So remember this point. Then I'm not going to detail a lot of slides where there are dialysis, I'm not going to the details. The most important thing which I want to tell all of you, as Luciano Gattinoni in the Red Book has mentioned, your present is someone's dream. So we are in a luxury today, sitting in a very air-conditioned hall, listening to the most elite speaker. I am Abhyasi, as you know, I'm just learning from all of you. So most elite speaker. So someone dreamt of an extracorporeal therapy, so you are using it today. So that is the Red Book's forward, written by Luciano Gattinoni in the last edition. So this is a classic paper I'm going to share with all of you. This is the domain which we have discussed, but don't forget, your own organs are there. So, તમારો organ નારાજ થઈ જાય છે. જેમ તમે બહારથી કંઈ ખાવાનું મગાવો તો વાઇફ નારાજ થઈ જાય, એવી રીતે તમે બહારથી ECMO મૂકો. So the new concept in extracorporeal is the last slide, organ crosstalk. So there are 8 types of organ crosstalk happening. So the 4 is classified now. So they say, તમે એક મશીન લગાવ્યું તો બીજો અંગ નારાજ થશે. So I'm going to give you the last take home message is, the first type is the red, native. એટલે એક organ fail થાય તો multi organ થવાનું છે, we all know that. Then comes native artificial crosstalk. The examples are bleeding in patient with extracorporeal. All patients put on extracorporeal can bleed. Hemodynamics in ECMO, acute kidney injury in mechanical ventilation, acute kidney injury in ECMO, acute kidney injury in liver disease. This is called native artificial crosstalk. That is the second crosstalk happening in the body. The third crosstalk is artificial. So જે અમે આ પોઈઝનિંગ પેશન્ટમાં મેં મૂક્યું હતું, એને લિવર ફેલ થઈ ગયું. કેમ કે આર્ટિફિશિયલ વાત કરતા હતા અને હમણાં લાસ્ટ જે એલ્યુમિનિયમ ફોસ્ફેટમાં મૂક્યું, that the aluminum phosphate poisoning, we put it on ECMO and CRRT. CRRT ને filter is clot થઈ જાય because the pressures used was 5.5 liters on ECMO, 500 liters માં TMP જ ના બને CRT filter used to clock લાખ રૂપિયાનું therapy છે. So that's called artificial organ crosstalk. If you are having two extracorporeal, respect them, learn both, get the resident stand with you and learn the physiology and teach your nursing and the medical officers. The last is multi-organ crosstalk, which actually all of you know, and that is the commonest cause of death in your intensive care unit. એટલે તમારા બેથી વધારે machine ના લગાવતા and play safe because the shortcut is the longest distance between 2 points and in your life. Thank you all.
Thank you so much, sir, for such an excellent session on extracorporeal therapies. And if anyone has any questions,
For ECMO is so high, so sometimes we are losing that window period patient. We have seen so many patients which is optimal for ECMO because at the point of discussion, but because discussion is went for a few hours to 1 day, and by the time patient develop multi-organ dysfunction and all, otherwise patient would have survived with one organ support.
If you have to approach a step like documentary law, see many a times as you rightly said, delay થઈ જાય છે. Your cutoff should be 2 cycles of prone. Don't think that hypotension is a contraindication of proning. Do prone because hypotension is happening because of hypercapnia. Prone પછી પણ ના માને 5 days should be your own cutoff time. 5 days પછી ઘણા patient તૈયાર થઈ જાય છે. સર હવે કર દો. 7 days પછી તૈયાર થઈ જાય. The problem is we delay ARDS therapy by playing with machines called HFNC and BiPAP. So the paper published last year is NIV in ARDS. Actually, they have given a beautiful algorithm. NIV માં તમે મૂકો ને આજે ઇન્ક્યુબેટ કરો તો પેશન્ટ આજે તો તૈયાર થાય નહીં. It actually the problem is ours because we have already lost first 5 days of acute lung injury ARDS. We feel that આજે ઇન્ક્યુબેટ કરીએ છીએ તો આજે ECMO કરશું. Most times nowadays what is happening in experienced unit is we do intubation for ECMO. That should not be the practice of care. HFNC per if your PF ratios are actually falling below 200, you have to intubate the patient. There was a paper actually contraindication. Your FiO2 more than 80 in one trial, as you read, was a contraindication to do ECMO. Contraindication to ECMO. So we have to actually tap them young, tap them early. Their lung is raw, amenable to recruitment, as he said. It is a heterogeneous ARDS. Early BiPAP is not. People are now doing ECMO and BiPAP also. That's not a bad idea. But તમે ઇન્ક્યુબેટ કરતા પોતો ECMO તો they are not ready for it because yesterday only you said કે BiPAP સારું છે because patient was very conscious. Disease trajectory માં within 5 days if you put, we don't lose people most of the times.
At present, I think window period is 4 to 6 hours.
Yes,
If
yes.
we are not able to convince the patient within 4 to 6 hours, so
Again,
I think from our side we should convince the patient as early as possible in specific of this sort of patient.
Yes.
Because otherwise after 4 hours if you are putting on ECMO, already lactate is so high.
So
I
yes,
think
you are right.
we
So
cannot-
that is where what happens is most of the initial ECMO counseling happens by only